This is Andrea Ribick. I'm the Director of Communications at HL7 International. Welcome and thank you for joining us today. Please be advised that during the presentation, your microphones will be on mute. When there is the Q&A session, you will be able to unmute to ask questions, or you may do so via the Q&A box in Whova. Dave, are you ready? I can't hear you, Dave. You might still be on mute.
Yes, I am ready.
There you are. Okay, great. So Dave Hill is our speaker today, and he is going to be presenting the PACIO project. Dave, the floor is yours.
Great. Thank you very much. And thanks to everybody for attending and finding out more about the PACIO project. My name is Dave Hill. I'm a principal engineer at MITRE, and I'm a co-founder of the PACIO project. I've been working in private industry for many years, developing solutions in a number of different areas, including disk storage, desktop publishing, interactive television, and green energy. I've been working at MITRE and in the healthcare space for the last 9 years. I've been doing work with CMS, including the Division of Chronic and Post-Acute Care, otherwise known as DCPAC, and Medicaid, as well as the Veterans Administration. So this session will inform you about the PACIO project and the background of the project, the use cases and the artifacts that we've been developing, including implementation guides, reference implementations, and the status and progress of each of those use cases, and then also how to get involved with the PACIO project. So we're going to talk about the PACIO project, give a little bit of a background and what's prompted this project. Talk about the 4, arguably up to 6 use cases that we're working on: functional status and cognitive status, reassessment time points, SPLASH, which is speech, language, swallowing, cognitive communication, and hearing, as well as advanced directives, interoperability. And then cover a little bit about what we did at the May HL7 Connect-a-thon. So the PACIO project is really, the patient story is about the post-acute care patient, and this is a significant portion of our healthcare system. 45% of the people that leave an acute care facility go into some kind of post-acute care. And so often these patients are very, very complex. They have a number of different stops in their healthcare journey. And so communication and transitions of care are extremely important. Unfortunately, that often is not the case. And so as a result, there's medication discrepancies and drug admissions and things of that nature, which can lead to very negative adverse events and can also result in readmissions. Also, folks need to try to rebuild the information, so they may conduct redundant procedures, and that creates inefficiencies and additional burden and cost. There's also a heavy reliance on the patient recall during periods of really high stress. And so as a result, the recall of that information can be unreliable, or patients may not be able to respond because they're unconscious or incapacitated. And this really increases the patient and family stress. Also, there is an increased cost and provider burden because providers then have to dig up at the information that's missing. And so that takes time. If you don't have all the information, as I said, that can result in adverse events, longer hospital stays, readmissions, and things like that, which we all want to try to avoid. And there's obviously additional administrative costs to locate and reconcile the missing information. So this all started through the CMS assessments. CMS requires, through the Impact Act of 2014, that post-acute care providers complete and submit assessments at specified intervals, and they're required to do this. And so usually it's at admission and discharge, but it could be also times in between. And there are several different types of post-acute care facilities. There's long-term care hospitals, skilled nursing facilities, home health agencies, inpatient rehabilitation facilities, as well as home and community-based services. And each of those have a different set of assessments that they do. So for example, long-term care hospitals perform long-term care hospital care data set assessments. Skilled nursing facilities perform minimum data set assessments. The OASIS, Outcome and Assessment Information Set, is done by home health agencies and so forth. So these all all these assessments contain a treasure trove of information, not only just about the patient as they move from facility to facility, but also for analytics. And so it's really important to be able to exchange this information and to collect it effectively. To help out with this collection, CMS created what they call the Data Element Library in 2018. And this standardizes and the questions and the potential responses for each of those assessments. And so that makes it so that the data that you're getting from facility A is going to reasonably match up with the data from facility B. And so there's continuity and some consistency between the assessments. So the PACIO project builds on that, and it creates a way, it defines a way to exchange information not only with CMS, but also across from facility to facility. So as the patient is moving along the various stops in their journey, the data is following with them. And so when a patient shows up at a facility, you will have the knowledge and the background of that patient. So we put together a collaborative effort across industry, government, and a variety of other stakeholders. We have several EHR vendors in the post-acute care space, as well as other vendors as well. And we also have multiple government agencies. We have CMS, ONC, the Veterans Administration, or Veterans Affairs. We also have several consortiums such as NASL and APTA, ASHA, and so forth. So it's really a great group of people, and that bring a lot of different types of expertise to the problem, and that I think should really help us succeed in putting together exchange standards that work in the real world. And you can visit our website at pacioproject.org, so you can find out more information there. So as I mentioned, we've been working on 4 to 6 use cases, depending on how you count them. But so functional and cognitive status have been the priority since the beginning, and those are the furthest along. Right now, those are in HL7 STU1 ballot. And then we've also been working with quality measures to build off of that. So in several connectathons where we've tested functional status and cognitive status data exchange, we've also been coordinating with the quality initiatives to take that information and calculate ECQMs, or electronic clinical quality measures. And we've been able to successfully do that. We've also started 3 new use cases recently. One is on advanced directives, to be able to exchange advanced directives information from place to place. Reassessment time points, which allows you to break up long-term care encounters into shorter windows or time slots. And then SPLASH, which I mentioned earlier, which is speech, language, swallowing, cognitive communication, and hearing. So let me start with functional and cognitive status. So MITRE's leading this effort, and really the goal here is to profile FHIR resources to allow the exchange of functional and cognitive status information to help improve transitions of care across care settings. Both of these implementation guides went through the January 2021 ballot. We've submitted 6 cognitive status block votes to the Patient Care Work Group, which is our sponsor of this work at HL7 for approval. And with the 6th one, which is yet to be approved but has been submitted, we will have addressed all of the cognitive status comments received during the ballot. We're also at that, once those are approved, we'd be looking to start the publication approval process for that implementation guide. We've also put together about 40 different issues on the functional status block vote 1. So that's almost half of the comments that we received during the ballot period. So we'll be well on our way there as well. So the status, the use case for functional and cognitive status is this is what we've been doing over the connectathons for the past several times, and that is the patient starts at home, and we've coordinated with the electronic long-term services and support project as well. So scene one is where the care plan is filled out and built, and that is stored in an EHR system. Scene two, our patient, Betsy Smith Johnson, suffers a stroke and has to go to the hospital. So this hospital is able to pull up the care plan that was generated in scene one and then perform assessments on Betsy and store that information in their systems. An ECQM system is also able to pull that information and perform clinical quality measures on that. Betsy improves and is discharged to a skilled nursing facility. The skilled nursing facility is able to bring in all of the information that it was collected through the assessments at the hospital, as well as the long-term care plan. And they perform more assessments on them, on Betsy, and that gets stored as well to their EHR system. In scene four, Betsy is discharged back to a home health agency. The home health agency nurse is able to pull up all of the things that happened at the skilled nursing facility, all in the assessments, all of the assessments that were done at the hospital, as well as the long-term care plan, and able to hit the ground running with care for Betsy. And then all along the way in scene five, Betsy and the family can access this information through a web application or a mobile application and be able to track and be engaged in the care process. So this is the system diagram that we put together over a series of connectathons. There's 16 different systems here that are interacting using 5 different implementation guides to exchange the information. So we have a number of vendors also involved in this. So we have FHIR systems that is used to create the care plan. We did last in January, we did a very early version of the advanced directives. So we had MaxMD and AD Vault involved in that, as well as Alterum was the FHIR server for collecting the care plan. So the green items are in scene 1, the purple items are in scene 2, the blue items are in scene 3, the orange items are in scene 4, and the yellow item is in scene 5. So in scene 2, we're able to pull in data from the health information exchange. We had MyHIN involved in our track, which was great. That provided some rich patient data for us. We also had, a hospital client and an ECQM system that was put together by the clinical quality track. We had a hospital PAC assessment app that read from the pseudo-DEL. The pseudo-DEL is the data element, our version of the data element library. We took all the public information in the data element library and put a FHIR interface on it. So we were able to read through a single piece of code, read and display over 250 different assessments that we were then able to fill out. That gets pushed to the hospital EHR. In the skilled nursing facility, we have another PAC assessment app which does the same type of thing, pushes the results to the EHR. And there's you can view all of that stuff through a care coordinator app. We also reported this information through a new system we created called the Prototype Quality Reporting Assessment System, which had a FHIR interface that allowed us to push the results of those assessments using FHIR into that system. So now that system can perform analytics on the data and collect it. And again, that was also done at the home health agency. We used Matrix Care for that. They do EHR work in that area, and they were able to use our implementation guides to push data to that system. And then patient-centric solutions offered several different pieces. They had a transitions of care client app, which is used by the skilled nursing facility to see all the latest data on Betsy when she comes in for clinicians. They also did the patient web client, which so the family could follow up with what's going on. And then they also did a health data manager, which is what all of this information, all of the information that's getting collected gets posted to, so that the next step in the process can read all that information. And we also had IDEEM.me as an authenticated identity server. These are the participants. We had over 30 participants in the tracks at the various connectathons. And so we had a great group of vendors and really were able to show how this information could in fact flow using FHIR from facility to facility. These are some of the screenshots. So this is showing the assessments over time on Betsy Smith Johnson. As you can see, the trend is upward. So she's going from substantial maximal assistance required to independent on many of these. You can see a little diagram way over on the right for trend to see that she's getting better. And this is the kind of thing that we want to try to show. This is the cognitive assessments, the various cognitive assessments that were performed along the way. So there were some BIMS and PHQ-9s, MOCAs and BCAT assessments. This is the care plan. So Betsy wants to, one of her goals is to be able to dance at her son's upcoming wedding and wants to improve her balance skills. There's all kinds of other things like she needs transportation, needs health and nutrition information for her diabetes and so forth. And this is information, again, that flows as she moves from facility to facility. And then there's the functional assessments. And so, you can see the mobility status here, and then underneath you can see the questions and the answers. So you can see, each of the questions on the left and the answers that were entered by the clinicians as part of that assessment. So this is all done by patient-centric solutions, transitions of care. So there are several artifacts for the functional status project. We have project information on the HL7 Confluence site. You can go visit that. There's an implementation guide that's currently in ballot. Our ballot reconciliation. So please, you can take a look at that. We have a reference implementation client, which is open source under an Apache 2.0 license, which is a very permissive license. You can incorporate any of our code into your project or product. And then there's sample data as well. We have quite a bit of sample data available to, that really is used all throughout the use case. And then we also have test scripts, which are based off of ONC Inferno. And those are also open source under the Apache 2.0 license. Under cognitive status, we also have project information there as well. Under HL7 Confluence, we have an implementation guide. The client and the sample data and test scripts are all the same as well, since they're both cognitive and functional status are tested at the same time. Next, I want to talk about the reassessment Timepoints project. So Chris Pugliese from Matrix Care is leading this use case. This is kind of grew organically as we were discussing problems in the post-acute care space. So the goal of this is to create resources and profiles of resources to generate sub-periods of time within an extended post-acute admission. So when folks are admitted into a post-acute care facility, a lot of times it can be several months, years. It can be a really, really long time. And so if you want to try to access this information, you don't want to receive 4 years of data potentially. You want to be able to break this information up into consumable blocks. And so that's what the point of this project is. So we have a project scope statement, which has been approved by the HL7 Technical Standards Committee. It's being sponsored by the Community-Based Care and Privacy Work Group. We're working on an IG proposal, as well as we've developed an object model and are creating an implementation guide using FHIR shorthand. And we plan, this is going to be our focus for the CMS Connect-a-thon in July. So this is what we'll be working on. So if you're interested in participating, we'd be happy to have you. This is sort of an object diagram. So, we have the episode of care at the top, and then we have encounters below that, which represents the post-acute care admission. And then under that are each of the reassessment time points, which are based off of a profile of the encounter resource. So you can almost think of it as there's 2 layers of encounters underneath the episode of care to provide that extra layer of compartmentalism, so that you can, if you're interested in a particular area of where a patient was reassessed, you can then easily get to that information. And this kind of shows the same kind of thing where we have, the yellow box is really the episode of care, and then you have several encounters, and under each of those encounters, you have each of the reassessment points where, that's time periods where, a reassessment is done on the patient, the care plan may change, the diagnosis and the and the prescriptions and things like that may change as well. So for this, this one isn't quite as far along, but we have project information, again, under HL7 Confluence, and we have the project scope statement. We hope to have an implementation guide soon that can be looked at as well. So this is a sort of a developing use case, and we're gearing up for the Connectathon. So if you're interested, please let us know. Next, I want to talk about SPLASH, which is the speech, language, swallowing, cognitive communication, and hearing. Jamila Harley from ASHA, the American Speech, Language, and Hearing Association, is leading this use case. And again, this was another organic use case that came out of the membership of the PACIO project. There were several members that were interested in this. And so really the goal here is to profile existing FHIR resources to represent this data and to make sure it also goes across each of the transitions of care for the patients that have these issues. So the progress here, this is our newest use case. We've submitted the project proposal to HL7. We've received good supportive comments there. We've submitted a project scope statement. Patient Care Work Group is the sponsor, and Community-Based Care and Privacy is our co-sponsor. And we're starting to work on the data model, and that will eventually lead to the building of the implementation guide. So here we have, for artifacts, we have the project information as well as the project scope statement. Next, I want to talk about advanced directives interoperability. And this is one of the really big projects we've been working on over the past few months. Maria Moen from AD Vault is leading this use case. And what we're really trying to do here is profile resources to represent and exchange advanced directives content. Things like living wills, durable medical power of attorneys, personal health goals at the end of life, care experience preferences, patient instructions, and portable medical orders for life-sustaining treatment. The progress is that we have an environmental scan underway. If you know about advanced directives, you know that many states handle advanced directives very differently. And so we're looking through all of the different ways that they handle that, because we need to be able to address that. We're also been working on a draft FHIR implementation guide. So there's a link there to get to that implementation guide. We're trying to leverage as much of the CCDA work as possible and incorporating that in. And so far, we've received very positive comments on the implementation guide. So this is the process flow that we're been following. So we've finished the IG proposal, and we're currently working on creating the IG content and making it more mature so that we can go into a notice of intent to ballot, to submit that into ballot, and then reconcile it, and to then publish. So we're getting into the intermediate part of that process. Here's the use case for advanced directives. So there's 5 different use cases that we're focusing on. There's being able to create and store the information in the first place, then to be able to share it, to be able to query and access that content, to update it and to replace content as needed, and then finally to verify that we have the most current version of the advanced directive. There are several layers of content that are involved here. Those are divided into person-authored information, practitioner-authored information, and practitioner-authored, practitioner, both, the last 2 are both practitioner-authored information. So the first one is advanced directive information. That's just the basic, living will and all of that and the other aspects that I talked about. The encounter-centric patient instruction, that's for what the practitioners put in when they observe the patient in an encounter, and then the portable medical order for life-sustaining treatment. We are focusing on the first step here for ST1. So we'll be focusing on the other 2 later, but this is our initial focus. So we'll be doing all 5 use cases, but we'll be focusing on the person-authored information. So we've been heavily involved in the mapping process, and so there's a lot of different components to advanced directives, and so the items in green have already been mapped. The items in brown are being mapped. The ones that are in bold were in the original scope for our Connectathon, which we did last May, and I'll talk more about that. The things that are green but not bold are things that were outside the original scope, but we still tested anyway. So we got further along than we expected. And then the black italicized items are future additions that we're looking to add on. So we're making some good progress here. This is the way the general document is structured. So you have a bundle, which has the entire, all of the information, and that has composed of several different sections. And so we have things for, healthcare agent appointment and pointers to healthcare agents and consent for healthcare agents. We have the goals, preferences, and priorities personal care experience section. So that captures the personal health goals as well as the personal intervention preferences. End of life or severely debilitating condition is another section where we also use personal intervention preferences and some additional personal health goals, as well as portable medical order for life-sustaining treatment observation. Upon death, we have the autopsy observation and the organ donation observation, and then there's additional provisions for administrative information. So we have multiple artifacts for this use case as well. We have project information. Again, on the HL7 Confluence site, we have an implementation guide, which is pretty new. And so that's going through our own development and review process. And eventually we look to go to ballot. We have a reference implementation client. Again, this is reusing the pseudo EHR that we mentioned earlier, open source under Apache 2 license. We have a separate set of sample data for this use case, which you can download and take a look at. And then we also have separate test scripts under Inferno for this use case as well. Next, I want to talk about what we did for the May Connectathon. So really the three goals really here were to orient folks to what we're doing with the implementation guide and profiles, to basically be able to show that we can create, exchange, and query person-authored advanced directive information across multiple HIT systems, and also to show where additional revisions and clarifications to the IG might be needed to resolve issues. So we had 16 participants, including 80 Vault, Alterum, CMS, MaxMD, MyHIN, the Michigan Health Information Network, MITRE, and Patient-Centric Solutions. So we had 8 systems, ones that created the information. We had several who were able to store the information and several more who were able to receive. So we were able to show multiple systems interacting, and we were able to do that all successfully. This is the use case. So back in January, where we exchanged a sort of a PDF living will, we showed how we could do that, and that was sort of the background for scene 1. For scene 2, Betsy is in Texas at home, and she notifies her son Charles of her new personal advanced care plan. She adds that to her records using a customer-facing application, which then can be viewed by Charles, her proxy and son. Betsy then decides to move to Michigan, to her son's home, and so can update that information with MyHIN and then be able to query that and see it. Unfortunately, Betsy suffers an issue and has to go to the hospital, and so but she's unconscious. She's not able to speak to the nurse, so the nurse is able to validate her advanced directives information with her son Charles, and is able to view the ADI information from the EHR. And then finally, once Betsy is here, she goes back to her son's home in Michigan, and the social worker is then able to view this information as well through the home health agency application. This is the data flow that we tested in May. So we have the FHIR server which was done by AD Vault, and the client, my directives. So the client captures the advanced directives information, stores it to the FHIR server, and then another client, patient-centric solutions, is able to read that information and display it. And again, the purple is scene 1, blue is scene 2, orange is scene 3, and yellow is scene 4. So in scene 2, the client done by MaxMD is able to retrieve information from Michigan Health Information Network, which received the information from the AD Vault FHIR server. They are also able to push that information to another FHIR server at Alterum, who's then was able to send that information or respond to a query to the pseudo hospital EHR, which MITRE produced, to display that information. And then finally, patient-centric solutions was able to create a client for the home health agency to pull this information so that the home health agency would be able to get the advanced directive information. This is some of the screenshots from the May Connectathon. So you have the AD Vault in the upper left-hand corner. This is a consolidated CDA document, which we showed could be accurately recaptured in FHIR. We have the pseudo AHR from MITRE that was able to display the information. We have MyHIN, MyHIN open server, that was able to retrieve the new record and show it, and then have MaxMD, the MaxMD mobile application, pull it out and display that information from MyHIN. And then the patient share application done by patient-centric solutions at the home health agency, so that they were able to see what the advanced directives information was. So all along the way, everybody is able to see what's going on. So the notable achievements, we were able to successfully exchange data between 8 different systems from 5 developers, showing and using a majority of the ST1IG core data elements, which is great. We successfully demonstrated how the CDA document could be, instances could be moved into advanced directives information FHIR IG resources. We also posted a collection of the various document resources to multiple servers, and showed how we could share that information from server to server. We successfully generated the ADI documents using the document, the star document operator, and displaying that discrete information. And through the testing, and this is what Connectathons are all about, we identified some numerous areas of improvements needed for the implementation guide that were not known before during our initial development. So lots of things to work on. So things that we found out was that we need to better define the document operations. So as to what needs to be returned, there was some fuzziness there. We also need to further discuss whether there should be a generated document on the fly or whether it should be a snapshot in time document. We need to address how to handle witness information and guidance on how that information needs to be placed into the administrative information section. And then we also need to define where to put the contextual information. And there's various different levels and sections that might be needed. And so we're still working through that. So if you're interested in getting involved in any of this, please, we'd be happy to have you join our efforts. So there's a lot of related HL7 meetings. So we meet with several HL7 work groups, patient care, they're the sponsor for the functional and cognitive status, as well as now the SPLASH use case as well. They're co-sponsor to the advanced directives and reassessment time points. So they're basically involved in one way or another with everything that we do. Same thing with community-based care and privacy. Patient empowerment, we work with them. They are the sponsor. They are the sponsor of the advanced directives information, and so we meet with them on a weekly basis. And then the clinical quality information, they are the co-sponsor of the functional and cognitive status, and they've been the one working with us to supply the calculate the ECQM information from that. So there's a number of PACIO Project resources. You can go to the website, pacioproject.org. We also have HL7, our HL7 Confluence page. So you can, that has all of the meetings and all of their, so we typically have separate meetings for each of the use cases. You can see where those, when those happen and how to get involved. We have the GitHub, which has a number of different repositories. I think we're up to about 16 or 17 different repositories on all the various software that we're building, as well as other information. And then we also have a YouTube channel, which so a lot of the demonstrations and things that we've done out of the Connectathons are there, so you can see how the whole thing works in great detail. So I hope that from this you've learned about the PACIO project in the background. I hope that you've learned about the use cases and the artifacts that are involved in each of the use cases and how to get access to them. And I hope that you've learned how to get involved with the PACIO project, and we'd be eager, more than happy to have you join the project and join the work that we're doing. So I will be available in the speakers gallery, and also you can email me at dwhill@miter.org. Happy to hear from you. And thank you very much for attending. And with that, I'll open it up to questions.
Hi, Dave. We have one on Whova right now. It's fairly long, so I don't know if you want to read it or if you'd like me to read it.
Let me see. So I had to exit out of Whova because I couldn't get the volume all the way down, and I didn't want to get echoed.
Oh, yeah. I'm happy to read it for you. Would you prefer me to do that?
Sure. That probably.
Okay. Okay. So the question is, do you see these IGs being specific to post-acute care and transfer of care teams, or usable for folks who need cognitive or functional assessments, or have health proxies, living wills, advanced directives generally?
No, I think, we're looking for general, not just post-acute care. I mean, that's certainly, post-acute care is the reason for the project. We're doing this work under the sponsorship of the CMS Division of Chronic and Post-Acute Care. So obviously they're interested in post-acute care, but they're also interested in having this information flow between post-acute care and acute care. So, even though we're, I think we're bringing a little bit of, we're trying to develop solutions that work across healthcare, but we're also making sure that post-acute care needs are being addressed. I hope that answers the question.
Thanks, Dave. If any other attendees have questions, you're welcome to post them in the Q&A box, or you can unmute yourself. You do have that capability now.
This is Janice Karen from the Massachusetts Health Data Consortium. That previous question was mine.
Hi.
And so I just have a really quick follow-up, and then I actually thought of another question. So are there, so the specific assessments that are used for post-acute care may not be the same assessments that get used for other cognitive things. Are any of the, are the use cases built specific to those particular assessments that you mentioned were CMS assessments, or are they more general, or would they be easy to adopt?
Yeah, so we tried to make them as general as possible. So I think that there's, we didn't create different profiles for, say, for each type of assessment. So really, it's a matter of a list of, what we do is we take the questionnaire and the question. So getting a little bit into the weeds, perhaps, but the data element library and the FHIR API that we created, and this isn't live. This is just something that we did to show it could happen. Is that it uses a question? It provides a questionnaire resource in FHIR. So, and then the PAC assessment app uses that to create the form. The clinician fills out the form. That creates a questionnaire response. The questionnaire response is then broken out into an observation for each of the questions, and then that observation is then what's passed around along with the questionnaire throughout the rest of the use case.
Gotcha.
So the observation is really very open and it's very general. The idea is that through the cognitive status implementation guide and the functional status implementation guide, they would be able to represent the various different types of assessments, at least that we know about today. And I think that it's, I think there's a good bet that it would work as well for the future.
Wonderful. And I just also want to go back on the advanced directives. Mm-hmm. You mentioned that there are a lot of different state requirements, but mm-hmm. there are also particular states that don't allow for some of the standard things. Like I live in Massachusetts, and we don't really actually have the several of the concepts that are pretty common throughout the country. We have something called the healthcare proxy, and then we have like one or two other things, and I'm spacing out on what we don't support, even though I know. So are there ways, I know that you said you're trying to adopt all of the things, but are there ways to, like, are you doing this in a specifically geographically based way where you're restricting someone to what's allowed in their location, or how is that happening?
So yeah, that's a great question. And I think there's, we're looking at that from a number of different ways. So certainly one solution that you could have is that you could create a profile for every single state that would focus on the various different requirements and capabilities of each state within, advanced directives. The problem with that is that now you have 50 different profiles that you're having to deal with, and that can sometimes be overwhelming for, if you're trying to implement. Another way to do it would be to make it more general, and then have to be, and for the things like you said in Massachusetts, which isn't supported, you make those things optional, perhaps. We're still working through the exact way we might want to do that. But the thing is that instead of having it necessarily at the implementation guide level, keeping it general there, and then have another layer on top of that that's provided by the software, the business logic, so to speak, that would then evaluate that and see how that matches the state requirements. The reason why you might not want to do it at the implementation guide level is that things change quite a bit in the various states. And so, that means you'd have to update the implementation guide a lot, and that takes time to do that. So, we haven't made the full decision, I would say, but that's one of the things that we're looking at very closely.
Great, thank you. Yeah, I'll let someone else have a turn if they have questions. Thank you.
Yeah, so if you'd like to get involved in that conversation, we'd be happy to have.
Yeah, I'm going to take a look at that. Thank you.
Mm-hmm. Any other questions? Don't be shy.
Well, it sounds like you amply answered any questions that they may currently have. I think at this point we can go ahead and close out the session. And again, thank you for speaking today and for sharing your knowledge with us. And thank you to the attendees for joining us. If you do happen to have any additional questions, please post them in the Q&A box in Whova. They will be monitored. And we would also appreciate it if you would rate this session by clicking on the link in Whova under the session information. And thanks again to everyone. And that concludes today's session. Take care, everyone.